Great, thank you. And thank you very much for the opportunity to speak at this second half of our QI workshop. The title for the work that I want to present in the second half is around some work that we're exploring within the NPCA team around metastatic disease. And this piece of work is looking at determinants of variation in the diagnosis of men with metastatic disease at primary presentation. So the National Prostate Cancer Audit, within their annual reports, has been reporting on the proportion of men who are found to have metastatic disease when they are first diagnosed. And within our annual report of 2022, which we published at the beginning of this year, we found that of all the patients newly diagnosed with prostate cancer, 17% of them were diagnosed with metastatic disease at primary diagnosis between April 2020 and March 2021. And this has remained stable over time, and this is a reflection of a previous annual report where we were using data from April 2017 to March 2018, which had a number of metastatic patients at 16%. We know that as part of the NHS long-term plan for cancer, by 2028, the aim is that more cancers will be diagnosed at an earlier stage rather than at a later metastatic advanced stage. So as part of that work and within the NPCA, we wanted to investigate what patient characteristics may be associated with metastatic prostate cancer at diagnosis. And the aim of that was really to identify what factors may predispose patients to being diagnosed with metastatic prostate cancer at diagnosis. And we wanted to look at a few different essentially characteristics within that, for which I've identified them here. We wanted to explore the impact of a patient's age, ethnicity, deprivation, and geography. I mean by that the region in which a patient was living at the time of their diagnosis, a patient's performance status, and a patient's Charlson comorbidity score. In order to undertake this analysis, we looked at all men diagnosed with prostate cancer in England between the 1st of January 2015 and the 31st of December 2019, so a 5-year window of patients for which there were 216,777 men diagnosed with prostate cancer during that period. Of those men, we were able to identify the metastatic patients using their T, N, and M variable within the data, and we used their M variable, their metastasis variable, to identify the patients with metastatic disease. So any patients coded as M1 were able to be identified as being metastatic at time of diagnosis. The metastatic status was unknown for 16% of the patients, and they were therefore not included in our analysis. When we looked at a patient's geographical region of residence, we defined that by their NHS region, so the 7 NHS regions of England, and also by Cancer Alliance, for which there are 21. This slide depicts the key findings using that 5-year cohort of patients. And along the top, you will see that we've divided these into patients that had metastatic disease at diagnosis and patients that did not have metastatic disease at diagnosis. And you will see that of the total 5-year cohort, 16.5% of patients had metastatic disease, which correlates with the findings in our annual reports. We've then broken this down by the patient characteristics that I mentioned on the previous slide. And I hope it's clear from this table that you can see that increasing age, which we would expect, is associated with more patients having metastatic disease at primary presentation compared to the men at aged 60 or age less than 60. The next one is looking at deprivation. So this is a quintile score between 1 and 5, 5 being the most deprived, so patients living in the most deprived regions of England. Of those patients diagnosed with prostate cancer, 19% of them had metastatic disease, compared to the men living in the least deprived regions of England, for which they had a nearly 15% proportion of metastatic disease at primary presentation. When we look at ethnicity, patients of white ethnicity were found to have the greatest proportion of metastatic disease at diagnosis. And finally, I wanted to pick out the geography, so the NHS region for which a patient was living. You can see here, these are the 7 NHS regions of England, and you can see that in the northeastern Yorkshire, when we looked at just the men diagnosed within that NHS region, 20% of all men diagnosed with prostate cancer had metastatic disease at primary presentation. And just to compare that to the data that we have for London, for which all the men diagnosed with prostate cancer, 12.5% of these men were found to have metastatic disease at primary presentation. And this is some of the findings that has fed into the recent Prostate Cancer UK campaign and work that Chiara was mentioning earlier around the north-south divide. And I want to go into that in a little bit more detail in this presentation later on. So the key messages from that table are that patients of older age or greater social deprivation are more likely to be diagnosed with metastatic disease at first presentation. We've noticed variation between ethnic groups with a higher prevalence amongst patients with white ethnicity. We've also, as I just mentioned, observed some variation in geographical region. For example, the patients in the northeastern Yorkshire being most likely to have metastatic disease at diagnosis compared to any other NHS region that we report for. But finally, we obviously want to emphasise the importance of all men seeking medical advice as soon as they notice symptoms, rather than just within these certain patient characteristics. The one thing that I wanted to pick out of the work that I presented as part of that table and that formed our short report last year is the data caveats. And this has been important to drive future work for the NPCA around metastatic disease. And the first point I wanted to draw out is that data by geographical region is sensitive to the degree of PSA testing that is going on within that region. We, in that table, demonstrate that in London, for example, 12.5% of the men over that 5-year period were diagnosed with metastatic disease. But if London are performing a huge amount more PSA testing, for example, that would mean that they would have greater numbers of men with lower risk disease, which are then being captured in the non-metastatic group, which would then potentially lower the apparent incidence of metastasis within that NHS region. So is there evidence of this more over-diagnosis in London? And secondly, I wanted to highlight the issue of missing data. I did touch on the fact that we had unknown metastatic status for 16% of our patients, and those patients were therefore not included in our analysis. But on further exploration of that work, around 50% of those men did have a T status of T1 or T2. So we're looking at ways that we may be able to use clinical assumptions to further include more patients within this cohort. It's also important to say that 5% of the patients did not have ethnicity recorded. So I very briefly touched on the work that we're looking to do going forward around this work, particularly around geographical variation. And this is in conjunction with some comments which we appreciated very much from our clinical reference group. And we've also been working very closely with our team at NCRAS, and thank you to them for the additional data that they've provided us in order to explore this in more detail. Because our aim is really to explore patients with metastatic disease, not just as a proportion of men diagnosed with prostate cancer, but we want to do this as a proportion of the total population. So we want to be able to hopefully extract out any biases that may be coming from if an NHS region is performing more PSA testing and therefore having a greater proportion of low risk disease. So when we look at geographical variation, we also want to explore associations between metastatic disease and age, ethnicity, and socioeconomic status by that geographical region, so that we can start to explore some of these determinants within that work as well. But really, this is just a flavour of what's coming from the NPCA in terms of metastatic disease. And as I mentioned in part of the panel discussion earlier, we're also looking at treatment of metastatic disease as well going forward. So it's an exciting time for the audit in terms of looking at and honing in on this metastatic cohort of patients. So thank you very much, and look forward to any questions.